It's pleasure to invite Dr. Manoj Gupta, Senior Interventional Cardiologist, Trimurti Hospital. He will be talking about Canadian Cardiovascular Society classification of acute MI, newer insights.
Good evening, chairpersons and all the participants. And I think this is a very proud moment for all of us. And Dr. Alok has organized such a wonderful. No, this, and he has given opportunity. To meet so many experts, speakers, and my friends also who has come from, I think lot of speakers have come from all over India. And today, Dr. Alok has given me this topic, and since it's a last session and in the paucity of time, in next 15 minutes, I'm going to discuss Canadian Cardiovascular Society classification of acute atherothrombotic myocardial infarction. So we know that MI, regarding the diagnosis of MI, there is a lot of confusion and there is lots of controversy and confusion regarding the diagnosis, and we see a lot of patients coming to as a TROP positive, and we all know that not every TROP positive patient is actually a MI patient. So in 2018 there was revised universal classification of acute MI, where they have given definition, and there should be dynamic rise and or fall of cardiac troponin, and there should be some clinical scenario which should be consistent with MI, and along with rise and fall of troponin level, there should be symptoms of myocardial injury, new ischemic ECG changes, development of Q wave, or any imaging evidence on echo, MRI, or thrombus on angiography. So these are the patients who are actually cases of acute MI. And the universal definition of myocardial infarction, it has divided MI into many types, like type 1, type 2, type 3, type 4, type 5. So basically, this type 4 and type 4 is basically angioplasty related, and in common practice what MI we see are mainly type 1 and type 2 MI. The type 2 MI is basically non-atherothromboembolic mechanism. Basically, because of demand and supply mismatch, this type of MI happens, and in this classification which we are going to discuss is mainly this type 1 MI. And the type 1 MI is, the mechanism is basically atherothrombotic mechanism, where plaque rupture erosion leads to occlusive thrombus, and it leads to either ST elevation or non-ST elevation MI. There are other MI also like Minoca, where MI is without any obstructive CAD. So what we are going to discuss is basically this one, acute atherothrombotic MI. So we know that we are seeing lots of cases of ST elevation MI, and time is muscle, and basically two types of therapy presently we have, fibrinolytic therapy or primary PCI, and the aim of these two therapy are basically to salvage the myocardium, and with the availability of these treatment in timely manner, we are able to salvage myocardium as early as possible. And the prognosis, if you see, in even in developed countries, where in early days of 1990s, where mortality was around 20%, it has come down to around 7% per year. But even in developed country, last 4 to 5 years, there is not much of improvement in mortality, and the prognosis depends on many factors. The important factors are duration and severity of ischemia, and we know that many of the patients who develop MI, ultimately they develop some sort of heart failure, malignant arrhythmia, and or in long term, because of adverse remodeling, these patients develop chronic heart failure. with significant LV dysfunction. So till now, a new classification, there was no classification which was based on the tissue injury parameters. So this new classification, this has taken into the consideration the tissue injury factors also. So this classification has categorized MI into 4 sequential and progressive stages, and the sequence of escalating severity with each stages there is, and it translates into worsening patient prognosis with each stage. So this is a diagram of normal myocardium, where you can see there are normal the cardiomyocyte, this is the endothelium and blood vessel. So this is a pictorial diagram of normal myocardium, and this is the CCS stage 1. Basically in CCS stage 1, the MI is limited to edema only. So this is a kind of aborted MI, where timely reperfusion within golden hour is done, and the evolving wavefront of injury is halted pretty early, and in the best case scenario there is near perfect prevention of myocardial necrosis. So only very small amount of myocardium or myocardial injury is there, and that too is subendocardial. So basically this is a case of aborted MI, and here patient have cardiomyocyte dysfunction, and there is reversible loss of contractility, and viability is mostly preserved. So this is aborted MI, and in ECG you will get some transient ischemic changes. When you look at the angiogram, mostly TIMI3 flow is there, and this can be picked up by cardiac MRI, and you will show only some minimal edema. So for aborted MI, there should be more than 50% ST segment resolution on the presenting ECG at either 90-minute post-fibrinolysis or 30 minutes post-PCI. So enzymes are only minimally elevated, and on reperfusion ECG shows no evidence of or no significant new Q waves, and angiography is also normal. Stage 2, what happens here, you see the there you will see necrosis of muscle, but this endothelial border is actually vascular bed is intact, and necrosis here progresses transmurally, and final extent is determined by duration and severity of ischemia. So in what happens here, MI is with cardiomyocyte necrosis, no microvascular injury is there. So what happens here, this is a classical MI, this is irreversible damage, there you will get ST elevation MI, troponin is markedly elevated, and here also you will see TIMI3 flow. So what TIMI3 flow means, the flow is as good as in the normal artery, but that doesn't mean that your EF is okay or there is no necrosis. So infarction is progressed with significant cardiomyocyte necrosis. There is no evidence of no reflow on angiogram, and there is no microvascular obstruction. Now coming to this stage 3, here ischemic microvascular injury is hallmark of this stage. Here you will see cardiomyocyte necrosis, there is interstitial edema, and the microvascular injury is there. So this is the hallmark of this one. So what happens during occlusion, there is, because of in situ thrombosis, loss of vascular integrity, cellular plugging, myocardial edema, and this embolism, there is, because of this endothelial swelling, tissue edema or luminal thrombus, their flow is actually reduced at tissue level. So in this stage, this is also irreversible kind of, there will be persistent of ST elevation, and there is reduced flow post perfusion, and here also with the help of contrast echo or cardiac MRI, we can quantify the damage, or this microvascular damage can be quantified. So here you can see in this stage there is MI with microvascular obstruction and perfusion deficit on contrast perfusion echo or microvascular obstruction can be quantified by MRI. So here also you can see in MI, despite 90% of patients having TIMI3 flow, 60% of patients, they actually have this type of microvascular obstruction, and in long term their prognosis is actually poor. Now coming to stage 4, here injury is very severe, and this is all because of sustained ischemia and reperfusion injury. We all know that because of reperfusion injury, what happens? There is, along with cardiomyocyte necrosis and interstitial edema, there is myocardial hemorrhage. And this myocardial hemorrhage is actually what happens here. There is additional injury by blood extravasation into necrotic tissue, and hemorrhage driven infarct expansion is seen, and this actually doubles the infarct site. Because of deposition of this iron crystals in the MI tissue, they trigger a kind of sustained pro-inflammatory response, and this contributes to adverse remodeling in the long stages. What happens later on, there is fatty degeneration of cardiac tissue that is driven by macrophage activation, lipid peroxidation, foam cell or cereid production. So what happens, there is no modality which identifies this stage except MRI. And with the help of MRI, you can pick up the actual damage. And this is one stage above, we can say stage 3. So this is hemorrhagic MI. This can be ascertained according to CMR, and most of these patients, they have mechanical complications also. So if patients are having mechanical complication, this MC or mechanical complication to be added in the presence of these complications like VSD, free wall rupture, papillary muscle rupture. So we can say it like CCS stage 4 with mechanical complication. So with each progressive stage, there is the adverse event rate is increased. You can make out that once you cross this stage from stage 3 to stage 4, the MACE rate is increased by 2 to 6 times actually. If you look at the incidence, even in developed country, the incidence is of this type 1 is around 5 to 15%, and 25 to 40% they actually have this kind of hemorrhagic infarct. And no biochemical echo-angio based method is able to detect hemorrhage, and only CMR can detect, and the incidence is around 30 to 40%. What are the factors associated with infarct or injury progression? There are many factors actually. The most important factor are the longer delay to reperfusion and longer duration of ischemia. So these all 4 stages, they are not independent, but they actually build on each other. So they all reflect progressive and sequential damage to myocardium. So longer delay to reperfusion, longer duration, history of smoking, worse clip class, worse TIMI score, Q wave on ECGs, larger ST elevations, LAD territory, rescue angioplasties, post-procedural low TIMI flow or lack of collaterals, they are basically marker for severe injury. Now see, this epicardial perfusion doesn't mean that patient is also having good tissue reperfusion. Actually, time is very important. Once you give the timely treatment, even if you see after 4 to 6 hours, if you give, there is certain amount of microvascular damage or no reflow is there because of all these distal embolization, edema, spasm and all these things. So some therapy is actually needed so that we can prevent this tissue injury. So I'll conclude, not all MIs are same. We need to take into account the underlying tissue pathology, and this classification can be instrumental in facilitating development of treatment and ultimately help with delivery of personalized differentiated tissue directed care. And this also can help research in acute MI by providing the stages of MI as a useful outcome measure, clinical study endpoint and therapeutic target. Thank you.
Thank you, Dr. Manoj, for nice display of the stages of MI, which we only learn during pathology classes. So it's now on board. And any questions from audience?
No, one is we can risk stratify patients. We know that as the stage progresses, the outcome is actually poor. So one advantage. Next is we can utilize this classification for some therapies which actually improve tissue perfusion. Although we have very limited options, there are role of some high dose statins, GP2B3 inhibitor, which we can say that improves tissue perfusion to some level. Now some hyperbaric oxygen therapies, all these kinds, they are all in experimental stages, some new therapies. So these are the implications of this classification.
Thank you, Dr. Manoj. I think GP2B, they have a role in prevention of this slow flow, which is the marker of this microvascular dysfunction. Slow flow or no reflow, that is the very important thing. And even the flow is TME3, then still the dysfunction is there.
Now I request Professor Dharmen Jain sir to give memento to Manoj. Last term. Avoid.
Thank you. Good evening, all of you. So this is the last talk of this day, and I will be try to be very fast. As you all know, the definition of pulmonary hypertension now is a hemodynamic based definition, and the greatest change in the recent guidelines is the cutoff. Earlier it used to be more than 25 millimeters of mercury mean PAP, now it is 20. So this is one thing, and the other thing is the pulmonary vascular resistance. From 3 it has been brought down to 2. And why it has been done? Because the normal mean pulmonary pressure is usually 14 millimeters of mercury plus minus 3. So if we take 2 standard deviation, it comes to be around 20. Beyond that, there is increase in mortality and morbidity, and there is delayed diagnosis. That's why the cutoff has been brought down, so that there is early diagnosis and we can prevent mortality and morbidity arising due to this. Pulmonary hypertension as such is not very rare. Nearly 1% of the global population is suffering from pulmonary hypertension, and whether it is pre-capillary or post-capillary, ultimately the patient goes into right heart failure and there is death of the patient, and that is the final stage. Apart from the hemodynamic classification, the next thing is clinical classification, which is very important because all treatment management of PS depends upon the clinical classification. Group 1 is a pulmonary artery hypertension. Group 2 is PH associated with left heart disease. Group 3 is with lung disease. Group 4 pulmonary artery obstruction, and group 4 is multifactorial. The most common cause of pulmonary hypertension is left heart disease. Nearly 70% of all pulmonary hypertension is because of left heart disease. So unless otherwise it is proved, always consider left heart disease as a diagnosis of PH differential. When it is ruled out, then only you can go for the other clinical group. Today mostly we need to differentiate the group 1 from other groups, because the treatment of group 1 is entirely different as compared to the other groups. Whereas in the group 2 or group 2 to 5, the treatment depends upon the etiology. In group 1, the treatment is entirely different, and that is very important to differentiate between this one group and the other groups. Diagnosis delay in PH is a norm. There is nearly 2 to 4 years delay reported, and without treatment the mean survival is only 2.5 years. So if you delay diagnosis, the patient is already going to be dead in a less time. And the good thing is that with modern therapy, the mean survival has been raised to 7 years. So if we try to diagnose it early, we are going to give at least 7 years of life to most of the patient. Now coming to the diagnostic algorithm, it has been made very simple in the current ESC guideline. First, at the physician level, there is suspicion. In a patient with unexplained dyspnea or fatigue on exertion, always suspect pulmonary hypertension on the background of proper medical history, physical examination, ECG, the biomarkers and oxygen saturation. And if you suspect a patient to have pulmonary hypertension, go for the detection phase, where you have to rule out the lung disease and heart disease. You have to make out whether the patient is suffering from lung disease by lung assessment or heart disease by heart assessment. And in the detection phase, most important is echocardiography. Echocardiography will definitely tell you most of the things about this. and from echocardiography there is assignment of pulmonary hypertension probability. In the patient with intermediate and high probability, the patient should go for right heart catheterization for confirmation of pulmonary hypertension. So symptoms which are very common in early PH, it can be dyspnea or mild exercise fatigue. In advanced stages, there can be chest pain, syncope, and symptomatic heart failure. Signs according to in the early stage, you can have cyanosis or loud S2, RVS3. Signs of right heart failure in advanced stages. Signs of right forward failure like pallor and dizziness, cyanosis. These are some echo features, and this is the most important slide in this presentation. You have to look for the RV size, enlarged RV as compared to LV, the LV, the eccentricity index more than 1, IVC dilatation. Then you have to look for the RV function, which is measured by TAPSE. TAPSE less than 18 is RV dysfunction. By tissue Doppler, S prime less than 9.5 is RV dysfunction. And then you look for the RA size, RA dilatation, and finally the TR velocity. One thing to note here is that we do not look for the systolic PA pressure as estimated by echocardiography. There is cutoff dependent upon the tricuspid regarding jet velocity only, TRV. So based on the peak TR velocity, it is divided into 3 groups, less than 2.8 meters per second. In these patients, if there is no other sign of any RV involvement in echo, then these patients have low probability and they are most probably, you have to consider the alternate diagnosis. In the patients with less than 2.8 meter per second, you have some additional signs of PH, or if there is more than 2.8 meter per second, always it is in the intermediate to high group probability, and such patients should undergo a right heart catheterization to confirm the pulmonary hypertension diagnosis. These are the additional signs which I was talking about. It is divided into 3 groups. Group A is involvement of the ventricle, where RV is increased in size. Group B is pulmonary artery, where you can have a decreased RVOT assessment time, or PA diameter is increased, and group 3 is IVC dilatation, RA dilatation. From these 3 groups, either 2 signs from any 2 group is required for reclassification into an intermediate to high risk group. So if a patient is having tricuspid jet velocity less than 2.8 meter per second and there is no such signs, that patient always consider alternate diagnosis. If you are getting a velocity more than 2.8 meter per second or any of these signs from more than 2 groups, definitely this patient has intermediate to high probability and they should undergo a right heart catheterization. So right heart catheterization is required for confirmation of diagnosis, classification, which is very important for therapeutic purpose, severity, and vasoreactivity test. Choosing the right classification is very important. Group 1 is always the diagnosis of exclusion. This is important because if you try to give drugs which are made for group 1 PH, they will cause deterioration of the patient in other groups. Like if we are giving vasodilators in group 2 PH due to left heart dysfunction, this patient will land up to pulmonary edema. If you are giving vasodilators in the patients with lung disease, there will be increased perfusion mismatch and this patient will deteriorate. Also in CTPH, chronic thromboembolic pulmonary hypertension, if you are giving drugs and trying to treat the patient, then you are delaying the treatment because this is the only form which is totally curable, and this patient should immediately be sent for surgery or balloonplasty as required. So as I told, the most common group is group 2, which is nearly 70% of the pulmonary hypertension. There are some clues how you can diagnose or you can suspect the presence of group 2 disease in patients with pulmonary hypertension. Orthopnea and PND will never happen in the group 1 PH. Some presence of moderate heart disease. Presence of cardiomyopathy, either preserved or reduced ejection fraction. Risk factors for heart failure with preserved ejection like obesity, diabetes, hypertension, elderly, atrial fibrillation, sleep apnea, and CAD. If these factors are present, always suspect a group 2 disease, and in echo look for LA size. LA increased in size will never happen in group 1 PH. Now coming to the treatment of group 1 PH, the treatment of idiopathic, hereditary and drug induced PH and connective tissue disorder associated PH is same, and the current treatment is all based on risk stratification. If the patient, the first thing is diagnosis by right heart catheterization and looking for vasoreactivity test. If the patient is vasoreactive, then this patient should be given calcium channel blockers like amlodipine and nifedipine. If there is no vasoreactivity, then you have to look for the cardiopulmonary comorbidities. If there are comorbidities, only monotherapy is indicated, like PDE5 inhibitor or ERA. If there is no comorbidities, these patients should undergo risk stratification. If there is low to intermediate risk, initiate a combination therapy with PDE5 and ERA. And if there is high risk, also add prostacyclin, IV or subcutaneous injection. So these are some risk assessment tool. Now the mainstay of treatment, the drugs which are FDA approved, they are basically belonging to three groups: endothelin pathway, that is bosentan, ambrisentan and macitentan, and then nitric oxide pathway, PDE5 inhibitor like sildenafil and tadalafil, and soluble guanide cyclase stimulator like riociguat. And the third group is prostacyclin pathway, which are direct prostacyclin like epoprostenol, which is very less commonly used because of side effects, iloprost, which is inhalation, and treprostinil, which is very commonly used. And the newer drug is IP receptor agonist, that is selexipag. These are the currently approved drugs for PH treatment. Starting dose is for ambrisentan and macitentan, which are most commonly used in ERA. It is 5 mg for ambrisentan, which can be increased to 10 mg. Macitentan, it is 10 mg maximum dose. Sildenafil and tadalafil also very commonly used. Sildenafil is 20 mg TDS, increased to 20 mg TDS, same dose. And tadalafil start from 20 or 40 and the maximum dose is 40. So this is a short summary of the treatment. The patient is showing vasoreactivity. In those patients, oral calcium channel blocker therapy is recommended. Otherwise, if the patient is not vasoreactive, look for high risk feature. If the patient is having high risk feature, these patients should be on triple drug therapy, including prostacyclin analogs, ambrisentan and tadalafil. In the patient where high risk is not there, in those patients, dual combination therapy is recommended: ambrisentan, tadalafil, or macitentan and tadalafil. Some newer drugs in this group, recently sotatercept has been approved by FDA in this year, and the next promising drug is metformin, which is also has shown very good results in the recent trials. Fasodil and anastrozole is still under investigation. This is the mechanism of action of sotatercept. This is very different from all other available drugs. This is the only drug which is able to modify the disease progression in the PH patient. It is like it binds traps the ligands which attach to the actin pathway, and that's from that it decreases the proliferation of the smooth muscle cells, and in that manner it decreases the progression of disease. General measures which should be followed in all patients: physical activity and supervised rehabilitation. Immunization should be given. In the patient with RV failure and fluid retention, there are diuretic treatment. Patient with desaturation less than 92%, oxygen therapy. Correction of iron status. Anticoagulation may be considered. There has been no guidelines given because the benefit is doubtful still. ERA, riociguat and selexipag, they are contraindicated in pregnancy. Prostacyclin analogs and PDE5 inhibitors can be given in pregnancy. So in other groups, the main treatment is according to disease, like patients with PH due to drugs. The most important treatment is discontinuing the drug. In the patient with HIV, antiretroviral treatment, and PH with portal hypertension, treating the liver disease. And in all those patients, only single monotherapy is indicated. If the patient is not responding, then you can go for combination therapy. Left heart disease, group 2, vasodilators should never be giving because they can lead to pulmonary edema. Lung disease, optimizing the treatment of lung disease, and in some cases of interstitial lung disease, inhaled treprostinil can be given. WHO group 4 is very important because this is the only form it is potentially curable. In all patients, lifelong anticoagulation is indicated. Surgical pulmonary endarterectomy is treatment of choice whenever possible. If it is not possible, balloon angioplasty can be done. So summarizing today's talk, as I have told, pulmonary hypertension is not rare disease. It is nearly 1% of the global population. Definition has been changed. Mean pulmonary artery pressure to less than more than 20 and PVR to more than 2. We must classify the patient on the clinical ground because the treatment depends upon the clinical classification of the patient. Diagnosis, always try for early diagnosis because that is the only way where you can increase the survival of this patient. Before starting the treatment, always risk stratify the patient into high, intermediate and low group. Treatment is according to the risk stratification. In all other groups, treatment should be according to the disease like left heart disease or lung disease. First underlying pathology should be treated. And the only treatable form is chronic thromboembolism patients. In those patients, always try to diagnose and treat those patients timely. Thank you.
Thank you, Dr. Gupta.